Okay, class. Good morning to you all. So, am I visible and audible to all of you? You can write me in the chat box. Am I audible and visible to you all? Okay. Okay. Good morning. Good morning. Okay. Thank you for informing. Okay, then we can begin the class now. Okay. So today we are going to talk about sinonasal tumors. And we usually, when teaching to MBBS students, we usually keep the tumors as the last class because before being able to treat, okay, you do not have to treat tumors, but you definitely have to diagnose them. So before treating them, you should know about, you should be able to treat the inflammatory condition, the traumatic conditions, and the allergic conditions. As MBBS and as a medical officer, would be medical officers, you definitely need to know about sinonasal tumors because in case of nose, it is quite important. So by now you know that nasal obstruction is one of the most important presenting complaints of the patient who come to ENT OPD. And nasal obstruction can be due to various reasons. There could be congenital deformity like the deviated nasal septum, which can also be traumatic. Similarly, in allergy, in benign nasal masses, okay, that there are so many conditions causing obstruction, and sinonasal tumors is is condition that also causes nasal obstruction. And apart from obstruction, it also has so many other symptoms. So you need to know about a few diseases because you should not in patients of obstruction, your differential diagnosis should always be sinonasal tumors, and you should not be merely treating them as only other inflammatory conditions or other benign masses, right? So with any tumors, we need to classify them. So here you can see there is benign type and there is malignant type. Okay? All the tumors are divided into benign and malignant type. But in case of nose, it becomes quite interesting with this one intermediate type. And this one disease called inverted papilloma is a very interesting disease, and it is one of the most important differential diagnosis of the nasal masses, which or of the nasal tumors. And this is a very frequently asked question, especially for in the PG examination when we appear for our final examination in the short cases, and sometimes also in the long cases, this inverted papilloma, because it is very common, and it should be diagnosed and treated accordingly. Right? So, what are the benign tumors? Right? Simple papilloma, ossifying fibroma, osteoma, hemangioma, neurofibroma. In intermediate, we have only inverted papilloma. Similarly, in malignant condition, we have squamous cell carcinoma, adenocarcinoma, anaplastic carcinoma, transitional cell carcinoma, malignant melanoma, cerebral gland tumors, and rhabdomyosarcoma. Now, let us talk first about osteoma. Right? Osteoma are common incidental finding in frontal sinus X-ray. Right? And as medical officers, you frequently tend to send for X-rays, and so you should be able to diagnose this case, and you should be able to differentiate this from other diseases. So this is mostly an incidental finding, and the majority are symptomatic and do not grow. Surgery is done for symptomatic osteomas, or those that rapidly increase in size. Complete removal of tumor with its base attachment is done by bicoronal osteoplastic flap technique. Right? So you do not have to treat the patient if there are no symptoms, and this is only an incidental finding. And in case of osteoma surgery, we may need to involve the neurosurgeon during the surgery. Right? This is how the osteomas they look like, and they commonly occur in the frontal sinuses. And look here, there is the swelling. So this is the osteoma, and here is the incision, and all of this is degloved, and the osteoma is taken out, and then reconstruction is done. So this is how osteoma looks like. So you don't have to treat it if there are no symptoms. But if it is gradually progressing, increasing size, causing symptoms like pain and others, then it should be removed. Now tumor has been removed and the bone flap has been closed. And look here, the platings, there are plates and there are screws, right? And the bone has been repositioned. So ossifying fibroma. So it is also known as fibrous dysplasia. Right? Sometimes this can be asked in your MCQ. Right? Only sometimes normal medullary bone is replaced by abnormal proliferation of fibrous tissue, resulting in distortion and expansion of bone. In CT, there is ground glass appearance with regions of osteolysis and calcification. Treatment is by complete surgical excision. So whenever there is tumor, we mostly need to remove it surgically. So look how it appears like this, right? Ossifying fibroma. Now inverted papilloma, right? So you need to know about it, and as I said, this should be an important differential diagnosis in diseases in the tumors that you can see in the nasal cavity. So locally aggressive sinonasal tumor, it is also known as ringers or skinny papilloma. It is common in males between 50 to 70 years of age. It arises from lateral wall of nose. It presents as unilateral friable pale pink mask arising from middle meatus. Right? Now look at this point, unilateral. There are so many masses that are unilateral. Sometimes, okay, like inverted papilloma can be confused with AC polyp too. Because that is also unilateral. So AC polyp is also usually pale, but that is not pinkish, and all of them arise from the middle meatus. Right? So, like whenever we send for CT scan of, nasal mass or CT scan for PNS, so sometimes, the reporting is like this from the results. Okay, in the diagnosis or impression, it is AC polyp, intraocular polyp, rule out inverted papilloma. So this is a very confusing disease. Whenever if it is intracorneal polyp, then the management is of one type. But if it is inverted papilloma, the management is entirely different. So before going for any management, so the diagnosis is made, and the best way to do that is by pons biopsy or incisional biopsy, right? So what we do is the mass is protected from nose, and we have a pons forceps, right? Pons biopsy forceps. Just we take a pons, send it for histopathology, and the report comes. If in the report it says that it is AC polyp, then just we do functional endoscopic sinus surgery. But if it is inverted papilloma, then we need to do a more aggressive surgery. Now the treatment is medial maxillectomy and en bloc ethmoidectomy by lateral rhinoscopy or midfacial degloving. Right? So medial maxillectomy. So maxillectomies are of different types: partial maxillectomy, medial maxillectomy, total maxillectomy. Right? So you don't need to go into detail for that. This is an important maxillectomy is an important question for the PG students. Right? But these days, we are also doing endoscopic removal of the inverted papilloma. And there's also something called endoscopic medial maxillectomy. So because this is an intermediate type, and there are chances of it turning malignant. Right? Here you can see that squamous cell carcinoma is present in 10 to 15%. So this inverted papilloma should be treated aggressively. Right? So if only we remove the disease, that is not enough. Right? So we also need to remove its attachment, the bones where it is growing into, right? Or where there may be erosions, right? So all of that part need to be removed en bloc in totality, right? Next thing is inverted papilloma has a marked tendency to recur after surgical removal. That is why an aggressive surgery is required so as to remove all the small fragments and all the small parts, and we do not want to leave any tissues there, tissue behind, so that that may grow. And because it is neither benign, so we should not be casual with treatment of inverted papilloma. And as I just said, I know there is, it has the tendency to be malignant, right? And squamous cell carcinoma present in 10 to 15% of patients, which is a quite high number. So this should be treated aggressively. Now look here. So this is what we mean by anterior rhinoscopy. We take a speculum, either thuricum or Vienna's nasal speculum, which is inside the nasal cavity. So the differential diagnosis could be AC poly because it is unilateral inverted papilloma, or it can be hypertrophied inferior turbinate. Some it can also be confused with DNS, right? Rhinoscleroma, rhinosclerosis, so many conditions, right? So you can do a probe test, right, to see the nature. Sometimes juvenile nasopharyngeal angiofibroma can also present like this, right? But it has also different symptoms. So look, so whenever we take the history of the patient, in fact, these are the things that I should be that you should be learning in the clinical classes. So all the things like age, name, address, religion, and all of the things are very important because that will help us us to guide towards a diagnosis. For example, I said juvenile nasopharyngeal angiofibroma. So this is we'll study it in another part, when we are talking about the neck. So it usually occurs in adolescents, right, and male, right? So in such cases, if there is a 14-year-old child who has a mass like this and who bleeds, right? So we do not suspect inverted papilloma because inverted papilloma occurs in middle-aged people. Right? In the slide, I've said 50 to 70, but we have seen it even in 35 or 40 years old patient, and it is mostly in male. But this is in adolescent males, usually who are in their teenagers. Juvenile nasopharyngeal angiofibroma. So age is very important. So that is why you need to ask for their personal details like age and address. Similarly, some diseases are common in some particular districts of Nepal, like rhinisporidosis. It is common usually in the Tarai belt of Nepal, where the people, they have ponds and they go for bathing in the ponds like that, right? And if you're working in Pokhara or in Surkhet or Kathmandu, you may not see this disease in the people who are the native rhinisporidosis in the people who are native there, right? So interrhinoscopy will show you mass like this. And with any tumor and with most of the diseases of the nose, we always suggest CT scan, and the CT scans should be contrast enhanced. Lift intrathecal mass with opacification of maxillary ethmoid sinuses. Look here. So this is the Africa sign, right? So this is how it appears in inverted papilloma. So roughly the map of Africa, the Sahara is somewhere here, and you have the Morocco here, Gibraltar is around here, and this is the sub-Saharan Africa, like Botswana, South Africa, Kalahari Desert, they are all here. So this looks like Africa, and bone destruction of the lateral nasal wall, So because it is intermediate type, so it is not only limited to the mucosa, it will be causing bony erosion, destruction. Now, biopsy is always done before you go for surgery to diagnose the disease. So it is called inverted because there is inward invasion of hyperplastic epithelium into underlying stroma, right? And the histopathology won't show any evidence of malignancy mostly. Now, how do you treat it? There are different, treatment management options. So, medial maxillectomy is commonly done, and this medial maxillectomy can be done endoscopically too. This is lateral rhinotomy incision. From the middle canthus, it goes around the groove and around the alar groove and up to the columella. And because we need to remove the maxilla, so maxilla, it has so many processes, right? So these are the areas where we need to cut, right? eh? And that is how it is separated from the adjoining bones. Right? The bones they are cut, osteotomy cuts down, and the tumor is exposed, and the tumor is removed like this, and then the incision is closed. Right? Similarly, these are the other approaches. There is something called the midfacial degloving. Right? So in degloving, what you do is you take out all the tissues and expose the bone. So that is degloving. You retract all the tissues and then you find the bone and everything. So it is a more aggressive surgery. I know. So, but this is we prefer to do limited surgeries. I know, and even endoscopically, so that there will be little incision marks and lesser operative complications. Now that was about the intermediate type. Now sinonasal malignancy, right? Epidemiology. It is 0.5% of all body cancer, right? And 15% of all upper respiratory neoplasms. So that means it is also quite common. Right? 0.5% of all body cancer. Again, this means it is not uncommon, quite common. Right? Maxillary sinus is the most common. 80 to 85% are squamous cell carcinoma. Male to female ratio is 2:1. Commonly seen in 45 to 60 years age group. Now, risk factors, right? So this is occupational, right? So there is something called the hardwood dust, right? So if the person who is exposed to hardwood dust, then they are more predisposed to adenocarcinoma. Those working in softwood industry or the furniture industries that is with softwood, then they are more predisposed for squamous cell carcinoma. And similarly, all the risk factors are people working in the nickel refinery, chromium workers, and the people who work in tannery, okay, the boot and the shoe industry, the tannery and the textile workers. And if somebody is exposed to mustard gas, so that may cause predispose the patient for sinonasal malignancy. And similarly, human papilloma virus is also a risk factor. Maxillary sinus malignancy. So what are the clinical features, right? So this is why sinus malignancies are important, because the symptoms are mostly the same to that of maxillary sinusitis. Nasal stuffiness, blood-stained nasal discharge, facial paresthesias or pain, epiphora, right? So that is what you get in maxillary sinusitis too. There is nasal stuffiness or nasal obstruction, and there is blood-stained discharge and epiphora and all of these things. Now, how does or where does the maxillary sinus malignancy spread? So it spreads in any direction, right? जता पनि जान सक्छ. Superiorly, inferiorly, medially, है? So late clinical features, होइन? That was the symptoms, and these are the late clinical features. So if there is medial spread, so the clinical features are divided into which area or which side it is spreading towards. So in the medial spread, right, medial towards this side, right, towards the side where you have the osteometric complex. There is unilateral nasal obstruction, there is unilateral purulent nasal discharge, there is epistaxis, there is unilateral fiber nasal mass, right? So many conditions, so many clinical features that are also common to other conditions. If there is anterior spread, so then there is cheek swelling or invasion of facial skin. I know if there is anterior spread, there is swelling and the suspicion heightens regarding the malignancy. But if there is medial spread, then the patient can is managed for maxillary sinusitis or any other benign mass for several months in the periphery before he comes to a higher center. Inferior spread, expansion of alveolus with dental pain, loosening of tooth, poor fitting dentures, swelling in hard palate or alveolus. So like whenever you do the examination of nose, you should always do the ear examination and the throat examination, and the examination of the oral cavity, right? So because all of these are related, I know. So it is obvious from this, and suppose the this is spreading towards this area. So obviously there will be dental pain, and because of the disease, there will be loosening of teeth. When the person losing teeth, then you should suspect uh, a malignancy. Similarly, because of the increase in size, the dentures will be poorly fitting if the patient has any. And similarly, there can be hard palate. Right? So whenever there is swelling, and in today's scenario, I always suspect malignancy. So malignancy is it is also somewhat an ENT emergency, and you do not want the patient to wait and waste his valuable time in diagnosis. Superior spread, there is proptosis, diplopia, and ocular pain. Posterior spread, so pterygoid muscle involvement. Right? So there will be trismus. Right? Difficulty in opening up the mouth. So whenever the patient come to you and he said that, okay, I have difficulty in mouth opening, just do not send him like this. Right? So try to gather more history. I know. So before you send for CT scan, I know there are a lot of questions that you need to ask, and there are a lot of clinical examination that you need to do. And if some suspicion arises, then always send for CT scan. Right? Intracranial spread is by more from poet for MLS syndrome. Lymphatic, and if there is lymphatic spread, then there will be neck node metastasis in late stages, and lungs and bones and other parts will be involved in systemic spread. Right? Now, whenever you see something like this, right, suspicions will arise regarding malignancy. Right? And here the cheek has been involved. Look here, this is the alveolus. The alveolus is this area where you have the tooth, and it has there is swelling. And if the patient had the denser, then it wouldn't have fitted here because it has enlarged. Right? So now, okay, maybe you'll have the clinical classes or maybe not. So whenever the patient has, like you suspect a case of any nasal mass, even AC polyp, always examine the ipsilateral side, right? Just like here, na? The patient has come to you and there is a mass, and you think that it is AC polyp, right? Or it may be anything else. Right? There is a mass in the left side. So whenever there is a mass in the left side, all of these areas, the ipsilateral side. So this is the left side. If there is a mass in the left side, then this left part of the face is the ipsilateral side, and this is the contralateral side. So usually the malignancies, they do not cross the midline. So you need to examine all the ipsilateral structures before making any diagnosis. So you need to look for the ipsilateral alveolus, ipsilateral hard palate, and ipsilateral ears because of the mass. Even though it is just a benign mass, and it can go into the nasopharynx and it can cause a tubular occlusion. And so you should be examining the ear to see for any pleural effusion or retraction of the tympanic membrane. Similarly, you need to look for the eye, and similarly, you also need to examine the ipsilateral neck for any neck node metastasis because of the lymphatic drainage. So I hope I'm clear, right? Right? So masses, they can appear like this, right? They can appear in any form, right? Diagnosis, right? In masses like this, you cannot pass the endoscope here, right? Because it is occluding the nasal cavity. But there are some masses, small masses in the early phases, you can do the diagnostic nasal endoscopy, and you can suspect or make a diagnosis of the disease. Okay, extraparenal sinuses, they are not very helpful, but we can just order them and try to see what lies in the sinuses, or in the nasal cavity, and always go for CT scan, contrast enhanced, axial cut, coronal cut, and sometimes even sagittal cuts, and biopsy. Right? But you also need to know that there are some conditions where biopsy should not be done, right? And even contraindicated, not only not done, but it is contraindicated. There is a disease called juvenile nasopharyngeal endocardium. Because we are talking about nasal masses, so it becomes important for me to mention this disease. So in case of juvenile nasopharyngeal fibroma, the symptom is unprovoked profuse nasal bleeding. Right? Unprovoked. But provoking means like if you do proving, or if you touch it, or if you sneeze, that means some sort of provocation. But in case of juvenile nasopharyngeal, there is profuse bleeding. Right? There is profuse, a lot of bleeding, and it can occur without any factor, right? Just like that. So juvenile angiofibroma has a tendency for such bleeding. So in case of juvenile angiofibroma, you should not do biopsy because it will be havoc, right? So juvenile nasopharyngeal is not included in nose and sinuses because it doesn't begin there. It is mostly in the nasopharynx, right? And there are so many controversies regarding it. So we'll have a chapter about this, and you learn about it there, right? So in rest of the masses of the sinuses or nasal cavity, you can easily do the biopsy, right? Do the rhinoscopy. You will see the mass, take out a small piece, and send it for biopsy. And even in case of inverted papilloma or other benign diseases, the patient may bleed. So you may have to do the intranasal packing, or you may need to do some cautery, right? Chemical cautery or little cautery to stop that bleeding, and the patient can be sent on the same day. And once you see the report of the histopathology, and after that you plan the management options. This extra of the paranasal sinuses, look at the okay, this is the septum, right? Nasal cavity. Here is the nasal sinus, and there is a big mass including suspected mass here, but we do not know what it is. Just a suspicion, and the CT scan. Okay, look here how the mass is spreading to all the sides and how it has grown and eroded the bone, right, medially, laterally, and towards all the sides. There is something called Ongren's line, eh? Ongren's line. Okay, we have 10 minutes before the meeting ends, right? It may be possible for me to finish it in 10 minutes maybe. Right? If not, then we'll just increase. We'll start another session, right? Ongren's line. This is the Ongren's line, right? So what is the importance? So any masses arising superior to this Ongren line and mass arising inferior to the Ongren line, they have different prognosis. So it is an imaginary plane extending between the medial canthus of eye and angle of mandible. Suprastructural growth situated above this plane have poorer prognosis, and infrastructural growth situated below this plane have better prognosis. So if anything occurs here, it has a better prognosis. But if anything occurs here, it has poorer prognosis. Now, as with any tumor, right, there should be T.N.M classification, right? Tumor, node, and metastasis. Right? So T1 is tumor confined to antral mucosa. You do not need to remember all this. Just have an idea how T1, T2, T3, and T4 what they mean. So this is limited tumor and confined only to antral mucosa. And when there is the bony destruction of the hard palate and the middle meatus, it is called T2. And when there is involvement of the skin of the cheek, floor of the middle wall of the orbit, ethmoidal sinuses, posterior antral wall, pterygoid plates, infratemporal fossa, then it becomes T3. And when it goes to the orbit, cribriform plate, frontal distant sinus, skull base, and nasopharynx, then it is T4, right? So whenever even T4 that is divided into A and B, and T4B usually means the tumor is not resectable, right? So so this classification is important because based on this classification, for cancer we have different treatments. We have chemotherapy, we have radiotherapy, and we have surgery. So based on T.N.M classification, we choose the treatment of the cancer, whether it can be only treated by only radiotherapy, or if the patient requires surgery, or if the cancer is there's no use in operating, right? So is the cancer resectable or not? So usually it is said that there are so many papers they say that T4B is not resectable, but there are some great surgeon who says that there is no cancer that is not resectable. It only depends on the skill of the surgeons. So there are different school of thoughts. Okay, so treatment. T1 and T2. If it is T1, T2, there is surgery and radiotherapy. T3, surgery and radiotherapy. And for T4, surgery plus radiotherapy plus chemotherapy, because it has been spread to orbit, nasopharynx, base, sinuses, and in different areas of the world, they have different protocols. The protocols have developed based on the research. Like they do research on 1,000 or 5,000 patients, and they see that okay, uh, first do the radiotherapy and then do the surgery. The results are good, then we should follow this. Or if they do the research in 10,000 patients and they see that's first surgery done and then post-operative radiotherapy, then they follow that. So none of them are wrong. So all of these are evidence-based, right? Surgical options. So okay, there are different incisions, right? And there are different procedures like total maxillectomy, right? Weber Fergusson incision with malignancy limited to maxilla, radical maxillectomy with orbital exentration, right? And intercranial-facial resection. Okay, just do not go into detail. So just remember that maxillectomy is one of the mainstay of the treatment, right? Because sinusal tumors mostly malignancy mostly appears in the maxillary sinus, right? So that is why there are different sorts of maxillectomies that can be done. So in case of inverted papilloma, which is an intermediate type, only the maxillectomy will remove the middle wall of the maxilla is enough. But in tumors that are extending, right? So we need to do partial maxillectomy or total maxillectomy or radical maxillectomy, right? Total maxillectomy. Just go through the pictures. Like tarsography, I know the eyelids they are closed. That is called tarsography. And Weber Fergusson incision. Look here, the incision coming from the lateral canthus going to the middle canthus, right? Infraorbital and around this groove around the ala, and the lip is split, and look the middle the midline is not crossed and the incision is made like this, right? And all of this part is removed. The maxillectomies are done from here, right? So these are the osteotomy cuts that are done, right? And total maxillectomy is done, and look here, the incision has been closed, right? But there is also a big defect. So what you need to do is we need to ask the dentist to help us make the prosthesis. So that is kept here so that the food particles and the water they won't enter here, and the patient will have a normal life. Now, orbital exenteration. So this is the last topic, and hopefully we have 4 minutes. It may be possible for us to finish here, right? So orbital exenteration is done if the orbit is involved, involvement of extraocular muscle, and involvement of conjunctiva or sclera, lead involvement beyond a reasonable hope for reconstruction, and non-restrictable full thickness invasion through periorbital retrobulbar fat. The eye has been improved, the other eye is good, the other side is good, then so you need to remove it so that the disease doesn't exist. You know, it doesn't spread to brain, or it doesn't get metastasis. Right? The whole eyeball has been taken, and these skins they are closed, and sometimes prosthesis they are kept for cosmetic reason. Right? So this is how it appears after operation, and a prosthesis can be kept, and it looks like normal. The patient will have very good prognosis. Right? So there was one case where I had removed the orbit and close it. Right? So cranio-facial resection. So these are different forms of surgeries. I just know the name. So that is all. So regarding sinusal tumors, you need to know about inverted papilloma. It is an intermediate type, and then there are benign and the malignant types. Right? So For now, this sums up all the classes of the nose. And if we happen to meet face to face for the clinical postings, then I'll explain you about how to examine a patient, the clinical methods, and something about more about the endoscopic sinus surgery. And if it is not possible because of the ongoing COVID-19 pandemic, then I'll prepare a class, a presentation like this, and I'll explain, or I'll also try to find out some videos where they show about the examination of the nose, ear, throat, and all other strategy required for you as a form of clinical class. So I hope you are clear up to here, right? So before finishing those, I need to tell you that there are so many important topics that you have learned, right? And there are so many questions that you'll get your exam, either in the OSCE and the Viva and the practical, and of course in the theory examination, right? So go through your books, right? Because you have a lot of time and you're saving a lot of time, uh, because you don't have to prepare to come to the hospital and you're not wasting any time on the road, right, for commuting. So try to use the time and go through the books at least 2 or 3 times, right? So just that will help you to understand all the diseases. Okay. Okay. किसी ने एउटा मेसेज आएको थियो. Okay, thank you to students for being here in the classes. And okay then. So if any questions, then you can ask me, or maybe we'll try to form some online platform where we can interact, because this COVID-19 has taught us so many things and taught us how to use online media